Hello and welcome to the Project iCare podcast. This is a recording for healthcare providers who want to learn more about improving care for patients with substance use issues and addictions. I'm your host, Dr. Casey Claiborne, a clinical psychologist and research scientist at the University of Texas Dell Medical School.
And my name is Sydney. I will help narrate this podcast by defining terms, explaining concepts, and citing statistics that are relevant to the topic.
Have you had a patient who wanted or needed to quit smoking? On this week's episode, we'll be talking about smoking cessation and cigarette alternatives. Dr. Ted Wagener is the Director of Tobacco Regulatory Science Research at the Oklahoma Tobacco Research Center. He is also an Associate Professor at the University of Oklahoma Health Sciences Center. Welcome, Ted.
Hey, thank you for having me.
Well, Ted, let's just jump in and tell me, why do some patients struggle so much with quitting smoking? Why is it so hard to quit?
First, obviously, smoking is incredibly addictive. They estimate that about 33%, about a third of people who actually try a cigarette go on to become regular users. When people try to quit smoking, they start getting all those withdrawal symptoms, feeling irritable, feeling slowed down, gaining weight. People on average gain about 7 pounds. So for some people, that's something that they don't really want to have happen. So that returns them back to smoking. But also, kind of the bigger things are a lot of people feel that reduces their anxiety, their stress, their depression. And so it's a coping mechanism for them.
Tell me about, some ways that they can do that. What are some evidence-based methods for quitting smoking?
So the evidence-based for smoking cessation is good and all, but what we've just kind of found is that a lot of the intervention that we've developed to date is pretty weak. When you actually look at what percent of people actually quit, the Chantix, NRT, and counseling increases it from about 2.5% of people quit to about 5% of people quit.
Oh, wow.
And so essentially we see every year that about nearly 60% of smokers try to quit. But after a year, no more than about 3% of those have actually stayed quit. So it's a really difficult habit to break. That's for a variety of reasons.
Nicotine replacement therapies, or NRT, are devices that deliver nicotine in a cleaner fashion than combustible cigarettes and are utilized for smoking cessation. The different forms of NRT include chewing gum, transdermal patches, inhalers, nasal sprays, sublingual tablets, and lozenges.
With NRT and in counseling being largely ineffective, pharmaceutical companies have been looking for additional methods to make it easier for people to quit smoking, but also they've looked to regulators to help make it easier for them to get products into people's hands. At one point, in order for people to use nicotine gum patch or lozenge, they actually had to get a prescription from a physician. That makes very little sense, especially when you look at the abuse potential of nicotine replacement products, or what we've just referred to as NRT. Their abuse potential is not even a tenth of what the abuse potential of cigarettes are. And the amount of drug that they deliver, meaning nicotine, is also roughly either 2 times less or 10 times less than what you would get from a cigarette. So essentially, people have to work harder to get a poor nicotine delivery product. And it's also very expensive. So NRT used to be $60 for essentially what would amount to 2 packs of cigarettes, where you could just go ahead and buy a pack of cigarettes for $5.
The first form of NRT was available via prescription in 1984, but became over-the-counter in 1996. Since then, the market has expanded to provide a range of NRT products, as mentioned previously. There are also pharmacological interventions available for smoking cessation. For example, in a 2017 study, bupropion and varenicline were shown to aid smoking cessation in the general population, as well as those with severe mental illness.
So products out now, which I'm sure many people are seeing, like electronic cigarettes, are kind of changing not only what health regulators try to do, public health officials are trying to do, but also what pharmaceutical companies are trying to do. And so you now have products like old school NRT that aren't even being offered by clinicians very often because they don't think that they work. And instead, clinicians are being asked by their patients, should I use an e-cigarette? I'm using it. It's helping me stop smoking. What should I do? And usually, oftentimes, clinicians don't know exactly what to say. So it's proving to be an interesting dilemma.
Yeah, that's really fascinating. So I want to come back to e-cigarettes in a few minutes, but while we're on the topic of pharmacological interventions, you also mentioned potentially counseling or anything like that. What are some behavioral approaches to quitting smoking?
So your traditional counseling is usually cognitive behavioral therapy. So this is usually, 6 sessions of counseling where you're going to teach people, how to cope with their withdrawal symptoms, helping them find different methods. Most of the time, the most effective methods are to use nicotine replacement products, but it could also be, distraction techniques. If you're having a craving, kind of surfing that urge, as they say, trying to wait it out for about 15 minutes or so and seeing how that works. Also, there's been some evidence with mindfulness-based approaches that those can be really helpful. The trick with those in smoking is having people maintain in that program for long enough to see some results. There's high dropout rates. But typically, the counseling that gets promoted the most is usually through state tobacco quit lines. State tobacco quit lines really looks like brief motivational interventions, finding out where people are at and trying to elicit intrinsic motivation to get them to stop smoking. And again, the evidence is clear that counseling alone is not as good as counseling plus medication. Always medication is offered side by side, or it usually is.
The medications that Dr. Wagener are referring to are Chantix and Zyban, which are both FDA-approved medications that are available via prescription. Chantix reduces the effects of nicotine on their receptors in the brain, and the mechanisms that make Zyban effective are still unknown. Referring back to counseling resources, there are 54 quit lines across the U.S. and U.S. territories, District of Columbia, Puerto Rico, Guam, and a National Asian Smokers Quit Line. According to the Center for Disease Control, in 2016, over 1.1 million calls were made to a state quit line in the U.S. With 34.3 million adults smoking cigarettes in the U.S. in 2017, the percent of smokers who utilize the quit lines is approximately 3.2%. That's assuming one call per person. Therefore, while they have the potential for being very useful, the quit lines are an underutilized source of counseling for people trying to quit smoking.
So what do you think clinicians can do to help their patients who want to quit smoking? What recommendations do you have specifically for them?
Always ask. The worst thing you can do is just not ask if they're smoking. A lot of clinicians don't ask. They don't have time frequently. So first, just asking if they are smoking. Asking then if they're interested in stopping and if they would like help. Having clinicians deliver cessation interventions is helpful, but oftentimes the research shows, and my experience as well, is that they don't have time often to deliver it, and so they don't. What a lot of people are pushing for is instead for clinicians that don't have time, for them to ask the questions, encourage them to stop, and then opting them into a state quit line program where you ask the patient for their number and then say, is it okay if we have the state quit line call you? And then proactively the quit line calls. I think that is probably a method that has a better chance of actually getting the person to a person that can be the most helpful for them. However, if a clinician fully wants to handle the cessation themselves in the office, the key thing is, one, not to demand, try to force change, to understand that all change is inherently self-change. Scare tactics don't work at all. And so finding a way to elicit intrinsic motivation. And so that means a lot of asking open-ended questions, reflecting like you just did with me, and doing those sorts of things to try to find what it is that smoking may be preventing them from doing, and really figuring that out. And being okay with the fact if just now isn't a good time for them, but also doing your best not to do damage. And what I mean by doing damage is trying to push someone when they don't want to. What you're just doing then in the future is increasing the resistance for the next provider who wants to address that. And so just seeing it as we're all a team and it takes a village, and maybe you're putting the ball on the tee, but maybe the next provider helps the patient, knock it off the tee. And so not pushing too hard, open-ended questions, reflections still looks to be the best method clinicians can do.
Yeah, and it seems like being patient and waiting for that window of opportunity is key as well.
For sure. Yeah. And, there's been plenty of research on teachable moments and finding times, right after people have heart attacks, about 50% of them quit smoking. That's a pretty big teachable moment. But some of those people still do need help. And so it sounds crass, but maybe capitalizing on that and using that as an opportunity when they're feeling a little bit more vulnerable, they've been hit hard with something. So taking the opportunity to be supportive, but having them really explore their motivation at that time, because it's very apparent to them right then, obviously, what impact smoking can have.
Mm-hmm. So tell me a little bit about what withdrawal is like from smoking, and how hard is it really to quit?
It's pretty hard. One, I'm a former smoker. I can speak from my own experience, but it's tough. There is a lot of irritability. There's also just a bit of a boredom. And for people that often are anxious or depressed, to them, it's self-medicating, whether it's having the real effect that they think it is, or it's just, more of like a placebo effect, isn't entirely clear. But we do know that cigarettes do have an MAOI effect. We know that they have certain chemicals in them that are anxiolytics. And so those feelings of relaxation that you get from smoking, the stimulant feelings, so having a little bit more energy to do things, and also just taking a break every hour to go smoke a cigarette, is now lost. Usually you see all the opposite of those then. You see, instead of relaxation, you see irritability. Instead of kind of feeling calm, you're starting to feel a little bit of happiness. You don't have that dopamine release anymore. You're starting to feel a little bit more sadness and more anhedonia. Also, a lot of smokers hang out with other smokers. So now they're not doing the smoke break anymore with everyone. So now they're starting to lose a little bit of their friend group and kind of the times throughout the day where they used to have conversations with people. Now they don't have that anymore. Then there's other things that come up too that are pretty big. Insomnia increases when people withdraw from nicotine. A lot of nausea occurs. Nicotine and smoking, it's a natural diuretic. And so people start to have digestion slowed down and everything. So they start having feelings of stomach aches and whatnot. So there's a number of symptoms like that really push people to go, is this really worth it?
Yeah, well, especially when you have so much going on in life, it's just like, I can imagine how difficult that would be.
Right. And it's funny because early on in my career, I really looked at helping parents who were smoking in the home stop smoking in the home so that their kids weren't exposed to secondhand smoke. Smoke has carcinogens and increases risk for a whole host of things for kids. And doing interventions with those parents, it was interesting to hear why they thought they were a better parent because they smoked in the home.
Wow.
And it was because they'd be a bad parent if they walked out of the house and left their kid unattended while they smoked out on the porch away from the house. Or that I'm not a good person when I don't smoke. I become anxious, angry. And so I'm a better mother, a better father because I'm smoking. So it's deep. You know what I mean? If it was easy to stop, it'd be easy to stop. It's a difficult thing that a lot of people, unfortunately, when they start, especially when people start as kids, they don't realize that addiction's easier to nicotine as a child. It then unfortunately becomes a lifelong addiction and takes a lot of effort, a lot of work, a lot of people kind of constantly point you down the path. A lot of also social pressures, clean indoor air laws, things like that not only protect bystanders, right, from secondhand smoke, that's part of it. But the other part is the fact that it also reduces what we perceive as normal. For example, my daughter, it wasn't until she was 6 that she actually saw someone smoking. And she said, "Daddy, why does that person have fire coming out of their mouth?" And I was like, "What?" I'm looking around thinking there's like some fire breather going on. And it took me a minute, and she pointed at the person, embarrassingly. And I was like, "Oh, that's smoking." I mean, I'm a cigarette researcher. And my kid didn't know what cigarettes were. But I remember being a kid in the car with my grandpa. I'm about 3-4 years old, sitting in the front seat, of course. And he's smoking a cigarette, and he would roll down my window so that the smoke would go out, but it would cross in front of my face. But how different is that? I was in an environment saturated with cigarettes. She, hasn't seen anything, and she's 6. And so kind of creating that social norm that smoking should be something that's rare and nicotine addiction should be rare. That's something that also plays into people's willingness to want to quit.
Mm-hmm. Yeah, that makes a lot of sense. And it also goes back with your example with your grandfather and rolling the window down, of how he probably viewed that as a harm reduction approach. He's reducing the harm because it's going out of the car, but not thinking that it's going right by you. And I'm sure a lot of the parents that you used to work with, they had harm reduction strategies that they thought were effective, and maybe they weren't so much.
Harm reduction refers to the strategies directed at individuals or groups with the intention of reducing harm associated with certain behaviors. Harm reduction approaches are utilized in the treatment of substance use disorder when an individual is unwilling to stop using at that time.
What are some effective ways to reduce harm related to cigarette smoking?
So reducing it to yourself, obviously quitting is the best way, right? But if you think about it, nicotine replacement products, patches, gum, and lozenge is a harm reduction technique. So you're giving them the nicotine, which is the addictive drug, but it's now in a clean nicotine delivery device. So that's what separates cigarettes from other forms of nicotine delivery is cigarettes not only deliver nicotine incredibly well, but they do it in a very dirty way because of combustion, because of burning. Whereas nicotine replacement products deliver nicotine pretty inefficiently, but they do it in a very clean way. That's why you don't see FDA or NIH trying to get people to stop using NRT, because we know the long-term effects of NRT are essentially negligible. Maybe something there if you have significant heart disease, but really negligible long-term use. When you think about harm reduction when it comes to cigarette smoke, you're looking for a product that delivers nicotine, but does it in a very clean fashion. The first harm reduction product ever was NRT, patches, gum, and lozenge. The next products that started to come out were products that looked very similar to NRT. Products like dissolvable tobacco, which didn't stay on the market for too long. They only garnered about 2% of the market share, and so they dropped out of existence. But really, the product with the most harm reduction potential is the electronic cigarette. And the electronic cigarette has really taken the world by storm here and has proven to be a disruptive technology. What makes the e-cigarette so unique is that it's the first harm reduction product that can deliver nicotine just as well as a cigarette, but does so in a cleaner fashion. And when I say cleaner, I'm talking about toxicological studies that look at what are the actual constituents in the e-cigarette aerosol versus the constituents that are in tobacco smoke. And when you look at those constituents, what you generally find is that e-cigarette aerosol contains anywhere between 400 to 600 times lower the amount of whatever particular constituent you're looking at. And so we believe that they're going to be safer for you. However, the jury's still out on that. Obviously, e-cigarettes have only really been out for about 10 years. And so we won't really know the long-term health effects of them probably for about another 20. But we can tell from past research that when you do reduce the level of these harmful toxicants, these harmful constituents down to these levels, that the health effects are likely to be significantly reduced. Even the commissioner of the FDA has said that if all smokers switched from cigarettes to using an e-cigarette or what's called vaping, that would be an incredible health benefit and probably the most significant public health benefit of this century. So e-cigarettes are likely going to be much less harmful and prove to be that. But right now, it is a little bit of faith and based on more very short-term studies looking at proxies of later health.
So one thing I hear all the time from patients who moved over from combustible cigarettes to e-cigs, and they repeatedly tell me that e-cigs are safe, that they don't cause cancer, and so I'm fine. What would your response be to patients who say that?
My response would be, one, I'm so happy that you've decided to quit smoking. Smoking kills more people than any other drug of abuse. 1 out of 2 people who smoke cigarettes die from a smoking-related illness. So good job.
According to the CDC, more than 16 million Americans are living with a smoking-related disease, and smoking is responsible for 500,000 deaths per year.
I would then follow up and say, when it comes to e-cigarettes, you're 100% right in the sense that they reduce your exposure to certain carcinogens and certain toxicants, cardiovascular toxins, things that are bad for your heart, because there is no burning. E-cigarettes don't burn anything, so you lose all those things that cigarettes have, like carbon monoxide and everything, that stuff that comes out of your car muffler. You don't have that anymore, so that's very positive. However, all the research show that they do contain carcinogens. What we don't know is how much of a carcinogen do you need before that leads to cancer? What is the effect of those toxicants on DNA damage and other biomarkers of effect that are linked to cancer? We don't know that they're 100% cancer-free. It is likely that they will cause some amount of cancer, but what you really need to do is never try to quit quitting. So just keep trying to quit smoking and then try to quit e-cigarettes. The safest option would be to quit with NRT. So if you feel like you're ready to make a jump to NRT, do that. And then when you're on NRT, try to quit that and get to nothing. If not, you have reduced your harm likely by switching to e-cigarettes. But it is not for certain that they're not going to cause cancer. But you make a good health choice by switching to e-cigarettes.
Now, are e-cigarettes safer for parents who are smoking and they're around their kids and reducing that secondary smoke inhalation?
Yeah, great question. So we actually just did a study about that. And what we do find is that children's secondhand vapor exposure leads to children being exposed to less nicotine and lower levels of carcinogens. It is still significantly higher than kids who live in non-smoking, non-vaping households. So a harm reduction again, but not better than not using anything. And so when you actually look at those numbers, it was approximately kids living in a vaping only household were exposed to about 15 times the level of nicotine that kids living in non-smoking, non-vaping households were exposed to. And when you look at a lung carcinogen called NNAL, you actually see that they're exposed to about 4 times the amount that kids living in non-smoking, non-vaping homes are exposed to. However, compare that to kids living in a smoking household, and what you find is that kids living in a smoking household are exposed to about 30 times the level of nicotine as those living in non-smoking, non-vaping households, and about 15 times the amount of carcinogens as kids living in non-vaping, non-smoking households. So again, a harm reduction, but kids are still being exposed to carcinogens. So the idea is you shouldn't vape where you can't smoke. They don't somehow purify the air, but it is a harm reduction.
Okay, that's really helpful. So I'm curious to hear more about like the role of hookah and other types of tobacco may fit into this conversation.
So hookah is very interesting. It's one of those products like e-cigarettes that really has caught on among youth, but hookah is just as bad as cigarettes. So there's no question about that. Hookah actually exposes people to more harmful toxicants than even cigarettes. So what's interesting about hookah is that every puff of a hookah delivers just as much smoke as one entire cigarette. The reason for that is, 1, what do we know about hookah tobacco? It's flavored. 2, it's sweetened. And 3, it passes through water. Now, the water doesn't purify a thing at all, but what it does is it humidifies the smoke and cools it and makes it easier to inhale. There's also very little resistance. Anyone who's smoked a cigarette knows that you kind of have to pull a little hard to get that smoke through that filter. But with hookah, there's no filter. The smoke just easily passes through, so there's not very much resistance at all. But then you have a flavored, sweetened, cool, and humidified smoke. So it's just very gentle on your throat. When you actually look at the full amount of smoke that people have inhaled after just 45 minutes of hookah, which is typically the length of time that people will smoke it, on average, they've smoked a little over 100 cigarettes worth of smoke. And that means that they're being exposed to oftentimes 2 to 10 times the amount of carbon monoxide and a bunch of different cancer-causing chemicals. So hookah is a pretty bad one. And while it's relatively new to the US, in the Middle East, in Asia, it's been used for centuries. Numbers coming out of there in recent years have shown that essentially you have similar or higher rates of lung cancer, lung disease, other cancers as well that you see from smoking. So again, not a product that kids should be using.
Mm-hmm. Yeah, that's really helpful. Is hookah as addictive as combustible cigarettes?
No. While kids like the flavors, most of the time you see that when people use hookah, they use very infrequently. But the reason for that is the nicotine levels in hookah tobacco are much lower than what you would see in a cigarette. In each cigarette, there's about 13 milligrams of nicotine. In a hookah bowl, you're looking at maybe around 3 milligrams of nicotine. So much less nicotine actually gets inhaled from hookah tobacco than from a cigarette.
Very interesting. I want to get to your research in just a second, but before I do that, I'm curious to hear what advice you have for clinicians. I know we mentioned earlier that, we have like 15 minutes when we're seeing patients in a primary care setting to actually do interventions and to do everything that we need to do in that clinical appointment. So our time is limited. How do we actually help patients who want to quit smoking? Where do we start?
I would start by asking them if they want to quit, if they're interested in it. Most do. Most will tell you that they want to quit. It's just motivation is ever changing. And so while they might want to quit right then, 10 minutes later when they're driving their car and something happens, they don't want to quit. So first is just see if there's interest. And then it's to follow up with why are they interested in quitting? And then listen very carefully because they're about to tell you what other things are important to them and what will be the things that are likely motivating them to quit. You want to then jump on those things and reflect, so maybe it's, I want to quit because my dad died of it and he died at a really early age and I have kids. I want to see my kids get married, whatever that is. And you want to reflect that. You want to say your kids are really important to you. You want to have more of a life with your kids than your father was able to have with you. Cigarettes took your dad away from you. Those sorts of things where you're reflecting not only what they say, but their feelings, and really trying to have them hear what they're saying to you so they can hear what their motivation for changing is. And you're reinforcing that thought in their head in that language. So start there and then ask them, what would it take to get you to quit? What's it going to take? Hear them out. Ask them then if they would like for you, even if they don't want to quit, how about we just get you some nicotine replacement products? You don't have to quit. You can just take them home and practice. Do a practice quit attempt.
Oh, I like that.
Just take a day and see if you can just quit for a day using these. Just practicing a quit attempt actually has the exact same success rate as actually doing 6 weeks of CBT for smoking cessation. And then offering even more help, advice to call a quit line if they want additional help, or to come back and see you, or you have a tobacco dependence treatment program in your state or in your county or your hospital or wherever you're at, having that on hand in case they want additional help.
That's great. That's incredibly helpful. And we will link to some resources for clinicians on our site at the end of this. This has been a Project iCare podcast with Dr. Casey Claiborne and special guest Dr. Ted Wagener. If you liked our show and would like to learn more, check out our website at sites.utexas.edu/Health Innovation Lab, or find us on Facebook at UT Health Innovation Lab. Our website, where to find more about Dr. Wagener, as well as the resources discussed today, will be linked in the description below. Thanks again for listening, and stay tuned to hear a brief introduction to Dr. Wagener's current research. I'm really curious to hear more about your current research and what you have going on in your lab.
Yeah, so my research area in tobacco is called tobacco regulatory science. And what that all stems from is in 2009, the FDA, Center for Tobacco Products, was established. What the Center for Tobacco Products is the division of FDA that's able to actually regulate tobacco. So up until 2009, we weren't regulating tobacco at all. But in order for FDA to now make regulatory decisions, they need science to back it up. That's where I come in. And the thing I love about tobacco regulatory science is essentially my research will influence what the laws are. So recently here in the news, I don't know if people saw, about the newest e-cigarette products like Juul, having flavors and things like that removed. Or, at the end of this week, FDA is supposed to make an announcement that they're going to ban menthol cigarettes, which would be huge, not only for youth, but for ethnic minorities. All of that is actually based on science and an accumulated science base that the FDA now can use to put that regulation in place and be prepared for the ensuing court battles that are likely to come. So that's the general research I do. And, specifically even for that Juul regulation that came down, that was largely from mine and a few others' research. And so it's very neat to be able to see research that was just done within the last 2 years then be applied in a regulatory fashion by the FDA. So generally that's where my research sits. What our research actually looks at is electronic cigarettes. Do they cause cancer? How do people use them? Do they help people quit smoking? Do they increase or decrease their addiction to nicotine? Do they cause heart disease? So when it comes to e-cigarettes, those are key questions. We also look at what are the things about e-cigarettes that appeal to kids, since kids actually use e-cigarettes at a higher rate than any other age group. When you look at high school students, they're actually using a higher rate than adults. So, what makes it appealing to them? And is it just the advertising? Is it the flavors? Is it something else? And so we look at that both in the human laboratory. We see about how is nicotine delivery for these products different for kids than adults. But, when it comes to advertising, I collaborate with a couple of people here in Oklahoma who look at the psychophysiological impact of different ads. So we collect eye tracking, facial EMG to see what emotions they're having when they're looking at an ad, heart rate, skin conductance, so that we can help target what the appealing features of the ads are, and if kids are affected by certain features compared to adults. Because if we can show that, then we can tell the FDA, hey, this is targeting children when they include this. And so those should really be removed. Some of the research we've done showed that obviously having youthful looking models is something that kids focus on more than adults. Changes norms. It's kind of duh, but FDA needs science to prove that. In terms of e-cigarettes, those are some of the things we do. The other stuff that we do is actually around hookah tobacco and flavors and sweeteners. And so we do studies looking at what happens if we remove flavors and sweeteners from hookah tobacco. How does that change how much people smoke, or if they want to continue to smoke? Just the inside track on that is flavors and sweeteners both increase the likelihood that people want to smoke and will continue to smoke. And as soon as you remove those, you see a lot of people stop using the product. So if you made something taste really bad, nobody wants to use it anymore. These aren't earth-shattering, but again, very necessary to make these regulatory decisions.
Absolutely. Ted, you're doing amazing work. And so please keep doing what you're doing. We definitely need this.